Have you ever wondered what's happening inside your mouth beyond the daily brushing and flossing? The truth is, our mouths are more than just tools for eating and speaking. They're a window into our overall health. Sometimes, the first signs of serious health issues appear in the most unexpected place: our oral cavity. Today, we're diving into the world of oral salivary gland infections, exploring how conditions like tuberculosis, leprosy, and salivary gland infections can all manifest inside our mouths, affecting not just oral health but our entire well-being. These infections may seem rare, but their impact is profound, and many times, they're first detected by dental professionals who know exactly what to look for. Imagine the swelling of a salivary gland or a small unassuming ulcer. This could be signs of something more serious, even a disease like tuberculosis or leprosy. The mouth, it turns out, is often the first place where we can spot these infections, giving us a unique opportunity to detect and intervene early. In today's discussion, we'll show you how these infections appear, what symptoms to watch out for, and the critical role dentistry plays in identifying and addressing these diseases. Because in the end, oral health is never just about the teeth, it's about the health of the entire body. So, let's explore how understanding these infections can not only help improve our oral health, but can also save lives by detecting bigger health issues before they get out of hand.
Oral candidiasis is a fungal infection of the oral mucosa and caused mainly by Candida albicans. It is part of the oral flora of the mouth, but considering that it is part of the mouth, under any certain conditions, it can lead to overgrowth, hence infection in the tongue, buccal, or the palate. The clinical manifestation of the oral candidiasis, it can present in several forms, but we will focus mainly on the most common type. So we have the pseudomembranous candidiasis, or what it is known as the thrush. So this clinical manifestation has a white creamy plaques on tongue, buccal, or even in the palate. You can get this infection from the poor oral hygiene and immunosuppressions like diabetes, antibiotic that you take, something like that. And remember that plaques can be wiped off, but it can sometimes result to bleeding surface and can result to discomfort and altered in taste. In totality, when predisposing factors are met, immunosuppression for oral hygiene or whatever you name it, it can lead to plaque not in the teeth but in the tongue.
Hi everyone, I'm Abby Zambales, and today I want to take you on a quick but eye-opening journey into something that sounds simple but can be a sign of something much deeper. A condition known as pseudomembranous candidiasis, or most commonly known as oral thrush. Thrush might sound like it's harmless or even poetic, but trust me, it's not. It's an acute fungal infection that appears in the mouth, especially in people with weakened immune systems, like those with HIV, cancer, or even babies. And while it usually clears up quickly, in some cases, it lingers for months or even years. So, what does it look like? Imagine thick, white patches coating your tongue or inner cheeks, like someone spilled curdled milk in your mouth. Try to wipe them off and you'll reveal red, raw tissue underneath, sometimes even bleeding. It's painful, it's uncomfortable, and it can affect how you eat, speak, or even smile. Some experts believe these white patches and the red, inflamed areas are just different phases of some of these diseases. And here is the real villain, a fungus called Candida albicans. Normally, it's just hanging out in your mouth, minding its own business. But when our immune defenses weaken, it transforms, growing root-like structures called hyphae that dig into the outer layers of the mucosa. In severe cases, it doesn't stop in the mouth. It can creep into the throat, the esophagus, and beyond, especially in people with HIV. Thankfully, treatment is simple, with antifungal lozenges like nystatin or amphotericin. But remember, oral thrush isn't just about white patches. It can be a warning sign, your body's way of saying, hey, something's not right. And that's why it matters. Thank you.
So for the next one, let's talk about something that may sound a little complicated but actually affects many people, often without them even knowing it. It's called erythematous candidiasis. This is a fungal infection that happens inside the mouth. It causes red, inflamed patches, usually on the tongue or the roof of the mouth. It's caused by the fungus called Candida. However, Candida is normally already living in our mouth. It is a type of yeast naturally lives in the mouth and digestive tract, but the problem starts when it grows too much. So how does that happen? Well, there are several reasons. Maybe someone's taking antibiotics, which kills the good bacteria that usually keep Candida. Or maybe they are putting something inside their mouth, like inhaler for asthma, and not rinsing their mouth afterward. It can also happen if someone has diabetes, wears dentures, smokes, or has a weak immune system. In short, when the balance in the mouth is disturbed, this fungus can take over. So is it contagious? Not really. You usually don't catch it from someone else. It usually comes from changes happening inside your own body. But in rare cases, it could be passed through close contact like kissing or sharing utensils if the other person is already vulnerable with this. What are the signs and symptoms? So a person with this may feel a burning sensation in their mouth or notice a red shiny spot on their tongue. Some may have trouble eating hot or spicy foods, and in more severe cases, people might feel dryness in the mouth or changes in their senses of taste. So why does this matter? Because something as simple as redness or soreness in the mouth can be a sign that the body is out of balance. But the good news about this is erythematous candidiasis is treatable. Topical antifungal treatment, merely nystatin and amphotericin is given as lozenges or pastille. A whole group agents such as oral fluconazole tablets are useful in HIV disease. Remember, health isn't just about what is of use. It's also about noticing the small signs our body gives us, even the one that starts with a sore tongue.
Imagine waking up to a mouthful red spots or white patches that peel away like a tissue paper, leaving a raw, sore skin beneath. Now, these aren't just discomforts, they are messages. Messages from the microbes that silently inhabits our mouth, waiting for the perfect moment to tip away the balance, the peace, the pathology. Today, I want to tell you a story, not one infection, but a spectrum of oral and salivary gland infection that the dentist and clinician often confront. Now, some are subtle, others are aggressive. All of them are shaped by one thing, the complex world and the ever-changing relationship between us and the microscopic world in our mouth.
Syphilis is more than just a historical disease, it is a modern clinical challenge, and sometimes its earliest warnings are written right on our tongue. Caused by the bacterium called Treponema pallidum, syphilis progresses through distinct stages, each with its own story which begins in the mouth. In the primary stage, a patient may not feel sick at all. What appears is a painless ulcer at charts on the lip, tongue, or palate. It is subtle, heals quickly, and is easy to miss. But beneath that quiet surface, the infection spreads. Then, by secondary stage, the body reacts more visibly in the mouth. Soft raised plates known as mucus patches emerge. When these lesions emerge, they form nail trap, ulcer painless, yet highly infectious. Tertiary syphilis, though rare today, leaves lasting damage. The most severe oral sign is the gamma, a deep ulcer that can erode the hard palate and even perforate into the nasal cavity. At this point, it's no longer contagious, but the consequences are permanent. Then there's congenital syphilis, a legacy passed from mother to child. Here are the clues: Hutchinson's, incisors, Mulberry molars, and sometimes saddle nose deformities. These signs are etched into the child's feature even before they speak a single word. Diagnosis depends on serologic tests and microscopic examination. It spreads primarily through sexual contact in congenital cases. Despite being curable with antibiotics, syphilis remains a concern in both developed and underdeveloping regions due to late detection and underreporting. Oral health professionals play a key role in recognition, contributing to faster diagnosis, treatment, and control of transmission.
What if your mouth could be the first to tell you something was wrong? Not just with your teeth, but with your lungs. Hi, I'm Cayanan, and today I want to uncover the lesser-known face of tuberculosis. Not in the lungs, but in the oral cavity. Because sometimes, your mouth knows what your chest hasn't told you yet. Tuberculosis, or TB, is a serious infection caused by Mycobacterium tuberculosis. Most of us know it affects the lungs, but did you know it can also leave sites in your mouth? Now, oral tuberculosis is rare as a primary infection, but when it does appear, it's usually a secondary invasion, spreading through contaminated sputum or blood-borne bacilli. These lesions often show up at the posterior part of the mouth, possibly because of rich lymphoid tissue in that area. Now, TB shows up in three major ways inside the mouth. First, oral ulceration. These can look like long-lasting, painless ulcers. The tongue is most commonly affected, but you might also see lesions on the gingiva, lips, palate, or even the buccal mucosa. In children and teens, TB can appear as a single painless ulcer or even a white patch, often with swollen neck nodes. Second, we have tuberculous lymphadenitis. This is when the cervical glands in the neck swell. In pulmonary tuberculosis, the bacteria can spread through the lymph or blood or enter through cuts in the mouth. The main sign is a lump in the neck. At first, it's firm and can move, but later it becomes fixed and may develop into a cold abscess, a soft, pus-filled swelling that doesn't feel warm. Lastly, we have periapical granulomas and bone infections. TB can affect the jaw bones after dental procedures like extractions, causing painful infections and delayed healing.
Leprosy caused by the bacterium Mycobacterium leprae is a chronic infectious disease that primarily affects the skin, nerves, and mucous membrane. There are two main types, tuberculoid and lepromatous leprosy, each with distinct clinical features. Tuberculoid leprosy presents with dry, hairless, and anesthetic plaques on the skin, typically with well-defined borders. Neurological involvement such as sensory loss or motor dysfunction is common, especially affecting the face, leading to numbness or tingling. Next is lepromatous leprosy, the more severe form, results in widespread symmetrical erythematous lesions, often causing significant facial deformities like the saddle nose. It can also cause dental deformities and pulpitis with oral lesions that may spread via bodily fluids. From a microbiological perspective, M. leprae is an acid-fast bacterium, meaning it resists decolorization by acidic solutions, a key trait for diagnosing leprosy. It is an obligate intercellular pathogen that thrives in cooler parts of the body, particularly the skin and peripheral nerves. Its slow growth rate and ability to evade the immune system make it difficult to study and treat. The bacterium's transmission remains somewhat unclear, though it is believed to spread through respiratory droplets or close contact. In real-world scenarios, leprosy remains a public health concern, especially in tropical regions such as India, Brazil, and parts of Africa. Despite being treatable, individuals with leprosy often face stigma and social isolation due to visible deformities, leading to psychological and emotional challenges. Early diagnosis and treatments are essential to prevent permanent nerve damage and disability. The study of M. leprae in microbiology continues to drive efforts to improve diagnostic methods, treatments, and understanding of its transmission, aiming to eliminate the disease to affected communities.
Every day, your salivary glands silently support your health, helping you eat, speak, and digest. But what happens when these quiet helpers become inflamed? This is salidinitis, or salivary gland infection, a condition that can be either viral, which is most common, or bacterial, which is rarer. The parotid glands, those just in front of the ears, are the most frequent targets, and among the viral causes, one stands out: mumps, also known as endemic parotitis. Mumps is caused by an RNA paramyxovirus. It infects circulating T lymphocytes, which then carry the virus to salivary duct cells. Once inside, the virus multiplies, destroying tissue and causing acinar disintegration, swelling, and also pain. Eventually, the virus is shed in the saliva and spreads through droplets, making dental clinics potential hotspots for transmission. How does mumps appear clinically? It usually starts with fever, a sore throat, and a pure tongue. Patients often feel pain while chewing and tenderness just below the jaw. The parotid gland swells sometimes both sides, but not always at once. Trismus, or difficulty opening the mouth, is common, as is earache. Saliva flow decreases, causing dry mouth, bad breath, and even stomatitis. The course of illness can vary from just a few days of discomfort to 2 weeks of high fever. Fortunately, most cases resolve fully, but complications can occur, including meningoencephalitis, orchitis in adult males, and more rarely, thyroiditis or neuritis. But mumps is not the only culprit. In patients with HIV, salivary gland disease may present as gland enlargement or serostomia with histological findings like Kaposi sarcoma, lymphoma, or lymphocytic salidinitis. Another key microorganism is cytomegalovirus, a herpes virus that causes salivary gland inclusion disease, particularly in newborns and immunocompromised adults. It is identified microscopically by its classic O-eye inclusion bodies in salivary duct cells. Rarely, viruses like parainfluenza, echovirus, and Coxsackie virus have also been linked to gland inflammation. So, what's the big picture? Salivary gland infections, especially endemic parotitis, are more than a swollen cheek.
They reflect how systemic infections can manifest in the mouth. Recognizing clinical signs and identifying causative viruses like mumps, CMV, and those linked to HIV is essential, not just for diagnosis but for protecting the oral and systemic health for our patients. Thank you.
Acute suppurative parotitis is a painful bacterial infection that is commonly affecting the parotid glands. While it's less frequent today due to the improved hydration and antibiotic use, it still occurs in patients with reduced saliva flow or underlying gland abnormalities. Saliva normally helps prevent infection by flushing bacteria from the ducts, but when flow is reduced due to dehydrations, medications like anticholinergics, or conditions like Sjogren's syndromes, bacteria can ascend the duct and infect the gland. Contributing factors include the mucus plugs, salivary stones, and benign ductal structures. Clinically, patients present with swelling, often unilateral in the parotid region. The area may be tender with lateral displacement of the earlobe. Fast drainage from stent duct is common, and trismus may occur due to the pain and inflammation. Systemic signs like a fever or leukocytosis can appear in more severe cases. The most commonly identified organisms are the alpha hemolytic streptococci and the staphylococcus aureus. However, polymicrobial infections are frequently observed. Less common pathogens include Haemophilus species, Echinella corridens, bacteroids, and anaerobic streptococci. Rarely, organisms such as Mycobacterium tuberculosis, Treponema pallidum, or Neisseria gonorrhoeae may be involved. Diagnosis involves collecting pus, or preferably before starting antibiotics for gram stain and culture. Empirical treatment typically starts in amoxicillin or erythromycin in penicillin allergic patients. Supportive care is crucial. Maintain hydration, promote salivation like lemon juice, and ensure good oral hygiene. Severe causes may require surgical drainage. Once resolved, cyanography can identify underlying abnormalities that predispose to recurrence. This should only be done after the acute phase. If untreated, complications include cellulitis, osteomyelitis, airway obstruction, and even sepsis. Recognizing the condition early, identifying the causative microorganisms, and initiating prompt treatment is essential to avoid serious outcomes.
So the next time you look into someone's mouth or even in the mirror, remember, it's more than teeth and tongue. It's a dynamic ecosystem, a communication hub between our immune system and the microbial world. Oral infections aren't just isolated events. They are windows to systemic health, whispers from hidden pathogens, and sometimes alarms that something deeper is going wrong. As dentists and clinicians, our challenge is not just treat what we see, but also understand what it means. Because when we truly listen to the mouth, we hear the story of the whole body.
Did you know? Here's a quick fact. Did you know that there was once an island in the Philippines where people with leprosy were isolated? Welcome to Culion, Palawan. In 1906, Culion became the world's largest leper colony, home to thousands of people separated from their families. For years, isolation and treatments like chalmugra oil were their reality. But everything changed in 1981 when multi-drug therapy or MDT, a combination of antibiotics like dapsone, rifampicin, and clofazimine was introduced. This revolutionary treatment cured leprosy and made Culion leprosy-free by 1987. Today, Culion is a thriving community preserving its powerful history at the Culion Museum.